Good morning. I'm Marina Iskander. I'm a third-year cardiology fellow and future interventional fellow at Texas Tech University Health Sciences Center, and I'm here to present a very complex case of a vessel that was occluded, calcified, tortuous, and aneurysmal in a critical limb ischemia patient. No relevant disclosures. So this is a 70-year-old gentleman who presents with persistent severe resting leg pain despite conservative medical management. We're a big tertiary center in West Texas, and a lot of our patients are treated conservatively in the area. He came in, his medical history is significant for coronary artery disease with bypass, hypertension, hyperlipidemia. He is a former tobacco abuser. On physical exam, the right lower extremity was cool to touch, and you can't palpate any distal pulses or popliteal. And labs were significant for elevated creatinine, and he was known to have chronic renal failure stage 3. So our initial angiogram here, you can clearly see the calcium just based on angiography, but also as it flows down, it stops, and you can see a collateral that will flow in shortly. So. Also, flow below the knee is compromised. Sorry, 1 second, my video is not working. I don't know why.
I think it was, but it's slow.
Okay. You can also, so we were able to get a wire down through the calcified lesion. You can tell how the wire is going, that it's quite tortuous. And it's occluded from the mid-superficial femoral artery and distally. And here you can see that there's one single collateral supplying below the knee. We had a hard time. We did wire escalation, but nothing was crossing through, so we went ahead with a wire and a support catheter. As you can see here, we had a hard time crossing all through the calcium and all the turns. We did use ultrasound as well as angiography to ensure that we are still within the vessel. Now that we had the wire across the lesion, we were able to start our angioplasty. We initially did percutaneous angioplasty of with a scoring balloon of the SFA, popliteal, the TPT, and the posterior tibial artery. And given the extensive calcification in our flow wasn't as well as we wanted, and we had difficulty with balloon expansion, we decided to go in with orbital atherectomy. As you can see, going through the SFA and P1 segment. After our atherectomy, you can see the balloon expansion was much better throughout in the SFA, popliteal, and the TPT. And we also did balloon angioplasty below the knee of the posterior tibial artery. So we did a repeat angiography, and we saw this, and we definitely were scared for a second, thought it was a perforation, but we did a few more angiographies, and with the help of the ultrasound as well, we confirmed that it's an aneurysm. And we decided to go ahead and stent it with a 6x7 9mm stent to cover the calcified aneurysm. And also, on the next image, we did selective angiography of the collateral before and after the stent deployment to ensure that we had protected that vessel, as it was supplying our posterior tibial system. So after stenting, you can see we stented the SFA and P1 segment of the popliteal. Now we wanted to improve flow below the knee. We tried, our next target was the anterior tibial artery. We went ahead, we tried to do an antegrade approach, but we were unable to cross, so we parked it in the TPT trunk and went through pedal access and retrograde approach up to the anterior tibial artery and crossing over. We were able to wire up, with the help of the support catheter, up the popliteal, up the SFA. And at our sheath, we snared the wire, externalized it, and reversed it. And we started percutaneous balloon angioplasty of the right anterior tibial artery and the popliteal artery. We went from above, because through the pedal axis, we didn't have as much support, and it was a much smaller caliber vessel, but at least we had a wire and a rail to work on. So, and also we went and repeat balloon angioplasty through the stents that we had placed in earlier with a 6x200 balloon, and did the same from the popliteal. So now that we had established flow, repeat angiography showed that we actually, our flow was compromised, and we noticed that there was not much flow going through. So we realized at this point that the patient's IV line had infiltrated and anticoagulation was interrupted. So we went ahead with aspiration thrombectomy of the right SFA and the popliteal with angiojet. And post-thrombectomy, you can see that our flow had much improved, but still required a little bit of more work. So we went in and with repeat balloon angioplasty in the area with a scoring balloon of the SFA and the popliteal artery. So our angiogram of the distal superficial femoral artery post-aneurysm, you can see there is flow coming through. We've also we've secured the collateral flow as well in the collateral blood vessel. We did one final balloon angioplasty of the anterior tibial artery with the scoring balloon to improve flow below the knee. And our final angiography shows that we've restored flow through the SFA, the popliteal, the anterior tibial, and we've secured the posterior tibial supply. So this case was quite complicated because we dealt with multiple complicated lesions. It was a CTO, it was calcified, it was aneurysm, and we dealt with thrombosis as well, and the tortuosity of the vessel in a critical limb patient who really had no other options. 1 month after follow-up in clinic, the patient reported no leg pain. We did arterial Doppler at the time, and it was unchanged compared to the study that we had done immediately post-procedure. Thank you.
Sorry, do you have any axial imaging for this patient? You have your angiograms, but did he ever have a CT scan or an MRI or anything like that?
No, we didn't do a CT scan because he had chronic renal failure stage 3. We wanted to minimize contrast, so that's why we didn't do a
Non-contrast CT scan?
No, we didn't do a non-contrast.
I only ask because when you see this much ectasia in the SFA and the popliteal, you have to think that he may have had a thrombosed popliteal aneurysm. In which case, on the angiogram, it may look like a normal vessel or occluded, but the nice thing about axial imaging, even if it's without contrast, is you can see the aneurysm, like you can see the aneurysm sac. And it becomes important because the natural history of the popliteal aneurysm is that it will embolize distally, in which case you either need to exclude it, you do a bypass, or you cover it with a Viabon. So, you know, in some of the critical limb ischemia, I think you guys did a fantastic job opening it up and reperfusing the leg, but it would be important to make sure that this is not a thrombosed popliteal aneurysm, in which case you would have to think about whether he's still at risk of, or she's still at risk of distal embolization. And then I would check the other side too.
Thank you.
Good points, please go ahead. From below, I think. Yeah. Just speak loud, we can hear you.
Thank you for great program. Katsanaka from Japan. So I have a question regarding your stent choice. So first we see the BDX, so balloon expandable.
We used this, I believe the Supera in this case.
The
I
one
believe
that
so.
was balloon expandable.
The balloon expandable,
Why did you choose the balloon expandable? So I think in this situation, self-expanding line are no longer fit for PD situation.
Yeah, but why was the choice of a balloon expandable stent and not a nice
self-
self-expanding stent, whether covered or non-covered, right? Yeah, which, I mean, I agree with the question.
Yeah, I think the goal was to make sure that we well opposed the across the aneurysm. That was kind of a main goal at that point.